Good morning, everyone. A very warm welcome. Let me extend my welcome on behalf of HBI to this year's conference, and welcome to the Maple Room. My name is Matt, and I will be guiding you through the day's proceedings in this room. And I will also be informing you at the end of every session where there are other sessions happening so that you can get to the right place and see the speakers that you want to see. But there's no need to move just yet because we've got a fantastic session to get started in here. And I'm delighted to welcome the panel up on stage already. And I will hand over to Sharon to do the proper introductions. Thank you, Sharon.
Thanks very much. And welcome to our session on investing in the UK and Ireland. Although we have a predominantly UK panel here, so we'll briefly mention Ireland where we can. But just by way of introduction, I am Sharon Lamb. I head up the Health and Life Sciences practice at McDermott. We're an international law firm. I'm based in London, and our practice is across the healthcare services as well as life sciences spectrum, and we act for investors in the space as well as operators. And I'm really delighted to welcome a really fantastic panel. I'm going to ask them all to briefly introduce themselves, just a few minutes each, as we have lots to talk about. But one of the things I wanted to mention about today's panel, and one of the reasons this is going to be a really fascinating conversation, is we have leaders across the subsectors in healthcare speaking today. And that's going to give us a unique perspective on those subsectors that first of all, our panelists work in, but also the opportunities. Now, I think there are going to be some common themes. Well, I hope so. But let me start first with Sebastian. Are you able to?
Yeah, hi, I'm Seb James, and it is my great privilege to lead the Vianet business, which is Europe's biggest ophthalmic chain of eye hospitals. I'm a newcomer to the business. I've been in the sector for 3 months, so I don't really know anything, and I'm delighted to be here. Before that, I used to run Boots, which is a pharmacy chain in the UK.
Well, that's a classic understatement, so I'll...
Sorry?
The understatement of I know nothing, we know that's not true.
Well, you'll find out for yourself.
Justin.
So I'm Justin Healy. I'm Chief Executive for Genesis Care across both its UK and its Spanish businesses. I've been there for 4 years, but have previous experience in the UK sector in both diagnostics and hospitals as well.
And Noel.
Hi everyone, I'm Anne Lomeni. I'm a partner with Apposite Capital. I started my career actually with Rothschild and Hedley Goldberg, who was on stage just before, and then moved on to invest on the investment side at Bridgepoint, and then Apposite. We're a healthcare-focused fund, and we do investing across all the subsectors that we're about to talk about this morning.
Brilliant. And finally,
hi,
but not least, Anita.
Nice to see everybody. My name's Anita Andrews. I'm the CEO for a specialist education and care organisation called Kishamel, which is UK-based. We look after children and adults with high complex needs, largely autism, severe learning disabilities. Been in the health and social care sector for 25 years. And predominantly NHS, and then more before Kishamel, which has been 3 years, a company called Virgin Care. So really pleased to be here today.
So as you can see, we have some very, very experienced operators and investors. I wanted to start with a little bit of a scene set on the UK kind of healthcare pressures and drivers, and some of the funding issues that have been top of mind, at least in the healthcare sector. To ask Justin, if you wouldn't mind kind of kicking off, kind of just a macro view of kind of the need for healthcare, waiting lists, that type of demand driver.
Yes, I think probably the start point is certainly for the new, relatively new Labour government, increased access to healthcare, almost agnostic of setting and sector, is a key tenet of their policy. The extent to which the reform that they need and the speed of recovery is achievable within the first parliamentary term is probably the big question, because clearly from a demand side point of view, there's more people presenting in various settings, primary, community, acute, diagnostic, for either diagnosis or treatment. And the infrastructure and the workforce currently really isn't there to be able to support that sustained provision over the longer term. So you've got the rising demand, longer waits, and some challenges with the physical infrastructure and assets, which I think sort of sounds quite downbeat, but I think from an investment point of view provides some really strong foundations for an investment thesis. You know, the reality is, however the recovery in NHS waiting lists and waiting times is addressed, there's a role for the independent sector, the third sector, that they have to play to be able to see that recovery so that more people are treated more quickly. I personally would take the view that we're seeing a structural change in the UK market, with more and more individuals choosing, or their employers choosing, to have private medical insurance. You know, you can look at Aviva and Bupa's most recent results, which show again another double-digit growth in insured lives. So people are actively choosing that access is important to them, and they'll dare I say it, you know, walk with their feet at the moment. It's that much of a priority. I think it's difficult to draw any meaningful conclusions at an aggregate level on self-pay. I think it's very sector and geography specific, but we are seeing, I think in the UK, a bit of a softening. But as I say, I don't think that's necessarily representative of some of the services that colleagues on this panel are providing. And then there's that really interesting question around, given the physical infrastructure and asset issues, the role private financing may play in helping address what is, you know, for many doctors that I talk to, simply intolerable conditions in their NHS practice. The net conclusion from my perspective is I think there is a lot of opportunity. If you're dealing with the NHS at the moment, I think it's about being patient. The opportunities will come, but we all know that they take time to move from sort of inception to realisation.
Yeah, and you've mentioned the waiting list there, and for those in the audience who aren't following our waiting list figures, according to NHS England's latest announcements, they publish our waiting list figures every couple of months. There are more than, well, almost 8 million people waiting for care, which is a huge proportion of the UK population, which is, you know, a sign in itself. And there is a target that 92% of people who need elective care will be treated within 18 weeks. And currently across the UK, or across England at least, where this is measured, it's standing at around 50%, although it's higher in some sectors. And one of the things that the Labour government said when they were at least on the campaign trail is that this Parliament, we would see a significant reduction in waiting lists and an increase in access to care, which brings me, Seb, to your thoughts on, and if we can talk briefly about some of the tensions that the Labour government has come up against, given some of the funding pressures, and what solutions are currently being debated and where we think they'll end.
Yeah, I mean, whenever I have a difficult day at work, I thank my lucky stars that I'm not the Health Secretary of the UK. You've got a fundamental problem, which is that you have waiting lists in some spaces, dermatology, for example, where a non-oncological case is about an 18-month wait to see a dermatologist, which is extraordinary. You have 8-month waits for orthopedic care. And therefore you have an urgent political necessity to deliver better quality care and to reduce those waiting lists. In fact, it's a guaranteed way to win the next election if they can do that. What's interesting to me is, well, we'll come back to that. On the other hand, you haven't got nearly enough money. So the Treasury has been extremely clear that they are unwilling to continue funding the overspend, which I think in this year is running to at about £7 billion of overspend from healthcare trusts. And therefore, a number of, in my view, quite nutty proposals have been made, including allowing ICBs to cap the amount of private care, or indeed any provider, that they that they commission to do work. I think that it is inevitable that will have an impact on tariffs, but in a way, it may well be that private provision is the solution to both of those things. So if I give you an example, in ophthalmic care, which is our space, about 4 or 5 years ago, when the NHS decided to make it a patient choice, i.e. patients could choose where they went, enormous amounts of effort and intellect went into building a private sector, with the result that waiting times went down from about 12 months to now approximately 3 weeks. And that is an extraordinary success, and that is driven by a laser focus from private providers on delivering extremely highly productive entities, and those are, of course, very profitable. My own view is that over time, the NHS will rightly ask of private providers, will say, look, we will give you more access to patients, and we are happy for you to make a profit, but we do ask that every year you deliver to us some productivity benefits. And I think that's completely fair, and by the way, would be fantastic news, I think, for everybody in this room. So, yeah, so I think at the moment it's a very turbulent situation. We don't know what they're going to do. NHS England is about to be dissolved. It's an enormous confusion, but fundamentally there are lots of people who are unwell and require treatment. The current setup is unable to do it. Access to private provision and capital is an incredibly effective and proven way of doing it. That's got to be good for investment in the UK.
Yeah, so you mentioned the abolition of NHS England. This made international headlines. It isn't actually the abolition of the NHS, which I did have some calls about clients asking if this was proposed.
It's like a Musk-like activity.
NHS England is the largest administrative body in the UK, or indeed, according to some of the press reports, in the world, and has expanded rapidly in recent years. What it does mean is, I think, some kind of questions about the timing for contracting. And Anita, we haven't spoken yet, you've got a different funding model, but in terms of the government's priorities on social care,
yep,
that's slightly been put on the back burner.
Yeah, I think it had already, been touted as a delayed review in terms of, adult social care review. It was due, in 2026 now, and now it's 2028, and now maybe with the NHS England news, it might be even later. And I know there's a big ask for, certainly that sector about parity of funding and integrated models, and we wait to see what that might bring.
And this always has a difficulty, doesn't it? Because the flow through hospitals very much depends on the funding into social settings.
Yeah, predominantly that's a sort of elderly care, sector. Myself, Kishimo, we're in a highly specialised area of care and education, but we get caught, in the same dynamic, in the same timelines, and continue to support, the funding flows to be addressed, within the social care sector.
So, Noy, I might ask you a question here. We've spoken about the waiting list, we've spoken about some of the drivers. I know that APSIT have invested in diagnostics, and I'm kind of interested in your perspectives on whether that remains kind of it's clear, it's needed to clear the waiting list. Without the diagnosis, we can't get patients through the system at all. What's your kind of outlook on the role that private providers can play in that market?
Well, we're very bullish about the sort of both the private sort of provision, because it's growing, and there are a lot of patients now, as you just said, trying to access more from a private pay perspective. But the sort of private sort of delivery for public pay is also very dynamic. I mean, on the diagnostic side, we are investors in an imaging diagnostics business, both benefiting from the NHS delivery, but also from the private so-called imaging holdings. So we've got a sort of private brand, which is definitely sort of growing super well on the MSK side, and sort of offering a really smooth access to care. And then obviously we've got the kind of NHS delivery, and it's growing, and it's quite dynamic. And then obviously there is issues on tariffs and potential risks around sort of new contracts and taking time to sort of deliver on those, but we're seeing really improved recruitment and retention of staff. We're seeing access to new sites as well from a real estate perspective, which is getting easier. Also, well, we'll talk about it, but potential acquisitions, smaller acquisitions is also easier to deliver. So we're seeing a lot of positive trend that makes us hopeful for that kind of future phase of the business.
And coming on to some of the other areas that you've invested in, Apposite's also had acquisitions and has assets in the dentistry space. Any thoughts on kind of that market? And
so it's interesting because, I mean, close to ophthalmology, actually, the dentistry space is really changing. I mean, patients are really struggling to access the NHS. There's no, London, wider area, Greater London, it's really tricky to get access to NHS. So this kind of, we've launched through Riverdale, which is our investment in dentistry, an affordable private offering, which is working really well. And it's really kind of access to appointments really quickly, same quality, obviously, and access to urgent and emergency care as well. So, we're seeing really positive trends as well in dentistry. Again, potential add-ons, acquisition, but also dentist recruitment, which has been really a big struggle over the last, say, 24 months. It's starting to ease. And
so the recruitment of dentists then, there was post-Brexit, I think we'll come on to this a bit later, but difficulty in recruiting. And in the NHS dentistry space, as you rightly say, there has been really difficult provision. Our newspapers describe NHS dentistry as a dental deserts across the country. So, I mean, that clearly is, on the one hand, as NHS care becomes harder to access, the opportunities in private provision just increase. But have you seen on the dentistry space some of the government initiatives improve the staffing and retention into dentistry?
So, it's been, it's slow to come, really. I mean, I feel that it's mostly been sort of private groups and various groups initiatives around sort of dentist academies and really training programs to take the staff and to retain them. It definitely, obviously, the increase in numbers and of dentists being trained and all this is helping, but it's going to be slow to materialize, really. But.
So, Anita, I'm going to turn a little bit to you because we spoke about Kishimul, but can you because it's a different type of care from the types of services provided by others on the panel, can you give us a bit of an outline?
Sure, no problem.
Let us know about the patients and service users you
So as I said earlier, we provide education and care to high acuity individuals who will present with sort of severe autism diagnosis and likelihood challenging behaviours. We deliver an integrated model. Actually, we really support that education and care together can really support somebody's life outcomes, as a meaningful life for somebody with that diagnosis is a really, really important and purposeful strategy for us. Slightly different in terms of, the guys have got here in terms of tariff funding. We don't have that. We have individual sort of contracts that we set the price based on what the individual needs, and all of our services are essential, so they are legally required to be commissioned and provided to the people that we provide support to. Bring it to life for you. For example, we've got a young boy who lives in one of our homes who was previously, I would say, to use, in confinement with 6 people watching inside a window, for example, on his day-to-day life. We were approached by a commissioner to ask to develop a very bespoke service for him. And I'm really pleased and very proud to say today he lives with us. He gets to go to the beach and get an ice cream, all of the things that, are important and may be taken for granted, but we're able to do that because of the specialist skills that we've developed within our organisation.
So that's extraordinary. So does that mean that for every kind of service user into your services, you have a bespoke package?
Yes. So every individual has a full review of what their needs are, what their hopes and dreams could be and what their clinical outcomes should be. You know, we've worked really, really hard on developing a new therapeutic model that pushes for independence for individuals and how we play a part in that and what our expertise and therapeutic sort of surroundings, whether it's just in education or in an integrated model. And each contract stands on its own and is very detailed, and we have 316 of them.
Wow. So now that's very different from ophthalmology, Seb.
I think we all have to tackle as well, which is in order for our business to be sustainable, resilient to political movements, et cetera, we have to answer a couple of questions. The first one is, how do you justify making profit out of that boy, or indeed out of my granny, you've just done their cataract, et cetera? So that's the first thing. Yeah. Second thing is, how do we tackle the question of, you guys are just cherry picking the most profitable cases, blah, blah, blah. The NHS is taking the hard stuff and you're doing the easy stuff and you're making money, no wonder, blah. Thirdly, you're taking all the doctors that the NHS has trained and you're then co-opting them into your business. And I think until and unless we have long-term answers that people actually believe to all of those questions, we're going to have constant pressure against us, and that will make the investment case more difficult. I think we do have answers. I also think we need to step up as providers. We need to train young doctors to become surgeons, or in your case, to become therapists. We need to be saying to the NHS, we will take any case. We need to do that more and more, and then we need to demonstrate an extraordinary difference in productivity. So I don't know about your areas, but in my area, an NHS doctor, often the same doctor, will do somewhere between 8 and 12 cataract operations in a day. In our centres, it is absolutely routine for them to do 24. So, yes, we borrow your NHS doctor, but we give you for that day 2 doctors. And I think that is a very compelling, and people go, well, how do you do that? It's very simple. The processes are worked out. It's a balletic process. I've been in it. It's absolutely amazing. And we just take away all of the paperwork bullshit, which is slowing down productivity. And the technology, you've got better, more modern technology. We can afford the kit, but it's less about technology. I think more about paperwork, and that our processes for bringing in patients, treating them, and how we work them through the system are just better. And of course they are. That's all we do. Yeah. And so I think making those cases is going to be the difference between people saying, okay, this is a long-term stable investment in healthcare in the UK, and not.
And I think there's an observation there because, if you look at what ophthalmology provision was 10 years ago, although it's hard to calculate, by all accounts, again, over here, various numbers, it can be more than 50 or 60% of routine ophthalmology is already performed in the private sector for the NHS. So that's no matter what the political dynamics are there, I think you've got the market being what it is.
And we still are. I mean, I'm still, whenever I meet NHS doctors and so on, they still say, well, how can you justify making a profit out of treating my granny? And sorry. Yeah.
Just to finish your point, similar. My person I've just described to you was costing the public purse a lot more in the environment he was living in before he came to us.
I'm going to turn to Justin now because we're going to answer the question of the NHS ideologies later. I want to speak to about Justin's services, which are all private services.
Yeah, largely. I mean, I agree with Seb's observation there around the need to convince and engage around training of the workforce. That in the UK, it's rare that there's a clinical workforce that when you roll forward 5 years has a sufficient balance of supply and demand. So on the one hand, while I agree with Seb, I do worry that there's going to become a point in time in the not too distant future, 3 years, 4 years, 5 years, where actually independent sector providers have to make a decision around how they want to be sure about the supply of the clinical workforce. And to some extent, it may well exacerbate some of the underlying challenges that you see in the NHS, because to the question you asked, we're certainly seeing oncologists make a conscious decision to reduce the amount of time they spend in the NHS because they feel absolutely flogged. So they're tired and they're exhausted. They're practicing, in some cases, in incredibly tired infrastructure with assets that need replacing and have needed replacing for 4, 5, 6 years, whether they're diagnostic assets or whether they're radiotherapy assets. And that presents a real moral maze for those individuals. And certainly we've taken the view in Genesis Care that whether you practice chemotherapy or radiotherapy, if you're the right sort of doctor with the right value set, and the counterfactual argument is you just walk away entirely from practice, well, actually, we'll buy sessions from you. We will employ you. Because back to the point around patients choosing now more and more to go private, it's our responsibility to make sure we've got the supply there. We'd like to have the sort of partnership that Seb talked about with the NHS, where we've got collaborative, mutually beneficial training. But I think, to the other point Seb made, the uncertainty around how that will be delivered given the changes in NHS England means I can't wait for that decision on their side to be made. We'll make that decision and proceed.
There's a bit of sophistry in that, isn't there?
Yeah, I agree. No, I agree. I think you're right.
But there's ultimately something there about what makes a good place to work. I mean, you are speaking about oncologists in the NHS working in extremely stressed and difficult environment. And whilst we might say that NHS England is just simply an NHS administrative body and the biggest quango, nevertheless, the abolition, somewhat unexpectedly or completely unexpectedly, depending on your perspective, is not a great morale booster. And so you must find that clinicians, and ultimately, I think this does filter through to patients, because the patients who are coming to Genesis Care are having an entirely different experience.
Yeah, I'd hope so. And certainly the feedback we get through both indirectly the consultants who practice with us, but also the patients in terms of their direct feedback does support that. But we've had to work really hard in the last 2 years to address some of the issues that colleagues have described today, that attrition. I think the NHS is probably more likely than not to see more attrition over the next 2 to 3 years because it is uncertain, it is very stressful. And I don't think it's just about pay. It's about that broader benefits and recognising the value and the importance of individuals in executing a really clear strategy for us, which is about putting the patient at the centre of everything we do.
Yeah.
So it's more of a values-based proposition than it is just, here's an extra £5,000 or £10,000. That isn't what motivates people now. It's part of it. I'm not going to pretend it's not part of it. But it's a far more rounded proposition, which I think generally in the private sector, we're probably a bit more flexible and agile and able to make those adjustments.
Yeah, and Laura, not to put you on the spot here, so do tell me to move on but you briefly mentioned some of the initiatives that had occurred in dentistry and who led those, being the private providers, because of course care had already shifted to private providers of dentistry, and it wasn't something that was led by government. So if you were talking to Justin and Seb's point here about private providers needing to take the lead.
Yeah.
In fact, this is something that
absolutely. I mean, absolutely. Back to Seb's point around sort of no-nonsense red tape and everything. So it's really having the right people doing the right tasks, and it's completely, the dentist will provide the care and the really high quality care, and so it's that, and having the right software and to allow for that smooth patient pathway and patient experience. It's also, building the right framework for dentists to be fully motivated. So JVs, for example, something we've, implemented. The right training, because obviously in the NHS, access to training is not, can be scarce or sort of unavailable due to obviously workload, etc. So it's providing that kind of keeping. I mean, clinical staff are really interested in keeping at the forefront of innovation, and so it's providing all that as well, which is important, and they want to stay in those settings.
Changing, I mean, your staffing model, very different from the staffing model that the others have been describing, and something probably that was a real question, again, after Brexit, but we've moved on a bit. Yeah, so, I remember, especially after the pandemic, there was the question, where do people want to work? Do they want an easy job with Amazon?
Yes. Lots of Amazon horror stories and social care.
How have you approached this? Because it's
Sure.
not the highest, not always the highest paid
It's
work.
definitely not. So in terms of the characteristics of our colleagues, we're talking about people who are close to national minimum wage roles. Social care is a well publicised, issue with vacancies. We've seen a much improved landscape this year. So I think from an adult social care perspective, we're talking 130,000 vacancies, which is about 15% reduction on last year. So we know some international recruitment has played a big part in that. But it's similar to what Justin said, which is back to the values-based recruitment and actually why people get into a vocation when you're talking about caring for others, caring for really vulnerable people and why that matters. We've gone on a huge transformation journey at Kishimal. Our turnover was pretty serious in terms of a number. Our vacancy factor was also, again, pretty eye-watering. We're pleased to say today we're in single digits on all of those things that, and it's been a huge effort, really redesigning competency frameworks, recognising training and what that means, how you can get people to stay in recognition of developing those skills that, then align with better outcomes for the people that we support. But the other big important thing is communication and engagement. That in social care, that's been a severe gap for quite a long time.
I'm interested in both Seb and Justin's perspectives. You're running businesses not just in the UK. Do you find that the kind of communications are different? Are there special messages that you need in the UK environment?
Yeah, because I think, sorry.
Go ahead, you go.
The NHS is unique in one way, which is that it is not so much a health service as a religion. And by the way, a religion to which I'm a believer. But as a result, it's the decision-making processes in the NHS, to my mind, unique in Europe, are moral ones rather than pragmatic ones. So if you look in Holland, where it's broadly speaking an insurance-based system, everybody recognizes that it's public provision, but it's public provision through private providers, insurance systems, etc. There's none of this talk of privatizing the NHS, and that is in and of itself a bad thing, etc. All of those discussions are, in my view, wasting time on which should be better spent on answering the very simple question, which is how do we massively improve and reduce the cost of provision free at the point of use in the UK. And I do think that we together, all of us, have an extraordinary role to play in transformation of the patient experience in the UK. I think we could do it. It requires enormous political will. Maybe we have it now, so maybe we're at a new dawn. But the UK is unique in that way.
Yeah, and I think, Justin, you mentioned this very briefly, but it was such an important point in your opening words. You mentioned about the double-digit growth and the kind of move in private insured care. So, I mean, that's already a significant change in the move away from the religion. So if NHS is the religion, I think that patients certainly are finding other churches. And that must be reflected in some of the Genesis Care story.
It is. I mean, again, you go back and when you look at the waiting list numbers that you referred to earlier, this isn't a new trend, and COVID wasn't the match that lit the fire. It was the accelerant that made it worse. You look at wait times in the UK, and they've been increasing gradually and then aggressively since 2009. And unsurprisingly, there's then a strong correlation with the increase in the number of people that actively seek out private medical insurance. The church question is an interesting one because, of course, to extend that analogy, probably inappropriately, so forgive me, you've now got certainly 2 architects, 2 priests, 2 conciliari at the Department of Health in Paul Corrigan and, advising Wes Streeting at least, Paul Corrigan and Alan Milburn, who were the architects of the initial opening up and expansion of choice for patients, agnostic of setting. And actually, when you look at what is happening or beginning to happen at NHS England, my view is that's almost a move back to the policy position that they began to adopt in the early 2000s. Now, we could be wrong, and there probably will be slightly more fiscal control put in place around the total spend available for the healthcare budget, but it does feel like we're moving back to a framework with which we're all actually quite familiar, but it's going to be clunky to get there.
I think it will be clunky to get there, but ultimately you can't move away from, I think it's Nye Bevan's quote about the bedpan clattering is heard in the halls of Whitehall, and the quality issues when the politicians can't divorce themselves from quality issues, which actually brings me on to a segue about what investors are looking for when they're looking at assets. And there's been a slowdown. The last few years has been quiet on health services, M&A and deals in the UK. So I think this is going to be an interesting time. Investors are going to be looking at assets anew, and we know that investors do have concerns about quality. How do they see under the hood? I mean, Anita, that's a question, especially in a kind of social care setting. I mean, what would you say about?
I think the first thing to say is, please, don't assume that actually the private sector isn't full of dedicated professionals that have done this job, for many, many years and are all very, very skilled. But what I work in terms of social care, we've got 2 different regulators. Regulatory regime continuously evolves. We have to evolve with it, and the appropriate thing for us is to make sure that all your quality assurance processes work, regardless of external eyes. We've worked really, really hard internally on developing that process, and also actually to widen the brief and talk about actually what matters to families, what matters to the individuals themselves. So I think for those of us that work in social care, you have to really, really have a grip operationally on your quality assurance metrics, and actually fundamentally make sure you deliver on those outcomes for individuals. So, for example, we've got a young boy that's joined our school who hadn't gone to school for 6 months, and now he's in all day. Those are the things that really matter, from my perspective on quality, and hopefully that's what investors want to hear about.
Well, let's ask. I know what are...
I find so, because we're also investors in social care, not just healthcare services, and we find that there are dedicated, managers who've been going through the ranks. I mean, we're investing in Swanton Care and Community, which is, as you do, has tremendous outcomes, and the CEO is actually, started his career as a carer, and so it's really growing through the organization and understanding all this ethos and the building of the training and of standards of practice for the and yes, there'll always be this human factor, but as long as there is the transparency and the growth in investing in people, I think that respect for the people we work with and the people we support, it feels like, I mean, that's the first thing we look at is the training framework when we look at investment, the surveys from employees, the churn of employees, and these are key indicators of the well-being of the workforce, because a healthy workforce and a happy workforce obviously leads to better outcomes for people supported. So.
Yeah, so that's an interesting perspective on that. So is that where you go first? You're looking at the survey data. Yeah. Justin, how do you check and kind of maintain a pulse on quality through your organisation?
I mean, in terms of where we operate, the facilities we operate in, we've got a very robust clinical governance framework, as I'm sure other colleagues prioritise here. So for us, almost sort of philosophically, the team worries about the quality and management worries about finance, and that's I would hate there to be a scenario where people felt they weren't making decisions on the front line every day without putting quality at the forefront of every decision that they take, and that's I think it's the same in all healthcare organisations, but because oncology is such an emotive and quite variable pathway, I can't have teams that need to make decisions in the best interests of a patient worrying about anything other than what's right for them, so they're empowered to do that.
So, kind of rounding this kind of out, we're starting off with March. Feels like it should be longer. I feel like the news cycle has aged me. I mean, I feel like we should be in July, but it is only March. We're looking forward to 2025. How do you see kind of the investment cycle in your own sectors? I'm going to ask everyone to contribute. Are you looking for kind of growth on an add-on basis, or is this organic growth that you're kind of striving for? Seb, what do you?
Well, our budget is for organic and inorganic growth this year. I hope we make it, and both in the UK actually and elsewhere. But I think that reasonable levels of organic growth are possible in our space. We will need to do productivity improvements because there is always a price-cost squeeze, and my hypothesis is that there should be, that health services should be requesting us to get better. And yeah, I think it'd be all right.
That's good. Justin, do you want to?
Yeah, similar. I mean, we're confident about the organic side of the growth. Back to the point around the number of individuals who are choosing to take out private medical insurance. We're putting down a new centre in Leeds, so let's call that inorganic, because it's not currently a market that we're in. But I think Seb's point on the cost base is right. You know, clearly one of the issues that agnostic of healthcare, all businesses are having to address is that compression in margin as a function of changes to whether it be national minimum wage or employer national insurance contributions, and that's just a fact of life. But it's probably a headache none of us really wanted, but we've got, so we need to deal with it.
I knew we wouldn't get through this panel without a mention of national insurance. And where were you?
Yeah, I mean, in a similar way, we were supporting our investing companies to both benefit from the obviously organic growth as well as supporting them with acquisitions. I think there are opportunities out there of smaller acquisition. Those markets are still very fragmented. With the CQC also framework changing, I think some smaller groups might be less able to sort of put the transformation in. So there are some small acquisition opportunities at attractive multiples. Greenfields are still a real opportunity in social care, for example. So quite positive on both from the organic growth as well as the inorganic.
And Anita, I mean, the impact investing remains important.
Yeah, I think sort of goes with the territory in terms of being in social care and the kind of ESG mandate. But I think the important thing about having the right purpose, what that sort of really conveys to people who are really keen to invest in kind of socially driven mandates. I think that's a really important sort of growth area, and we've got our own organic growth plans this year as well, so we're really sort of running with that, and we hope to do more of what we do today for more people.
So exciting times. Now, I'm telling you, this has been such an exciting discussion that the HBI team have taken down our timer ticker. They've reset it a few times, which I thought meant we were just to go again. Pardon? Another 10 minutes. So if that is, are there any, I have some more questions for our panel, but I wanted to check, are there any questions from the audience before we, yeah.
Hi, thank you very much. It was really, really interesting. My name is Arno. My job is to help international companies invest in the Paris region, so the other side. You talked a lot about NHS, talked a lot about professionals because, well, basically the root of your businesses. But there's one thing that you're not talking about is the current university crisis and how working or co-investing into universities could actually bring you a supply of professionals, because without universities there's no NHS candidates, and well, you wouldn't have any professionals to work in your businesses. I'll take for the dentistry, for example. Dentistry sector, you have a lot of universities, but some of them are currently going under or going on a very, very bad financial crisis. Newcastle, for example, Cardiff as well. So my question, because I also am a board member of one of British universities, is are you considering co-investing into university programs for medical sector, whether dentistry or medical in general, because without them, there's nothing.
No, Justin, I can see.
Yeah. I actually see the investment in two forms, and it isn't a question of if, because we're doing it already. I think the two forms for us that it takes is there's some fascinating research programs around how different types of, whether it be drug-based or radiotherapy-based treatments, can benefit patients. And so we work very closely with one of the leading academic universities around about the M4 area to actively fund research, which, albeit conducted in our centre, is led by the PIs there. I think a second element, which actually relates, I think, to the question you're asking as well, was around the workforce piece. And yes, we now fund, as I know a number of other independent sector providers do, specific training placements, undergraduate degrees, postgraduate degrees for members of staff. Again, recognising that the reality is, irrespective of the number of people, they often move between an NHS provider and an independent sector provider. So again, back to Seb's point, that's part of that moral maze/compass that we need to navigate.
Yeah, Seb, what's your thoughts?
Yeah, we need to have an end-to-end partnership with the NHS as our biggest partner. We need to help in the training of young doctors. We need to turn those doctors into ophthalmologists. We need to turn those ophthalmologists into surgeons. We're involved in pieces of that puzzle. We need to do more as a sector. We need to do more because we need to head off this idea that we're somehow piggybacking off a state provision in order to make profit. And until and unless we win that argument, we're not going to see the transition towards a much more blended economy, particularly in public healthcare provision, which will be transformational for patients, and that's our goal.
I completely agree on the healthcare services side. On the social care, we also need to be a bit more prominent in delivering the message of the purpose of those careers and what it can bring to people, and that also that training goes with it.
We have partnerships now with local universities that kind of support the kind of advancement of professional careers, support placements similar to Justin, but I think it's slightly Cinderella, and as you say, it needs to be a bit more loud in the market.
Slightly Cinderella, just in the kind of tone of it?
Yeah, I think it's just, it's, as we said earlier, the choice of career and what's professional and what isn't professional. I think the social care workforce, could really, Skills for Care exists for this reason, really, to try and sort of support people to see their career choice within social care as a professional qualification.
Are there any other questions from Chris?
Thank you very much for a very good talk. Just with the Irish economy experiencing year-on-year growth and budgetary surplus the last couple of years, I was curious to hear the panel's opinion on investing in Ireland at the moment.
Ireland is one of our key markets as well. To be honest with you, we haven't been very successful in Ireland just because of our lack of presence on the market. We have probably less senior advisors over there, so we're actively working on it. But it is definitely an attractive, market. It feels like the consolidation hasn't quite happened like it has happened in the UK, for example, in certain areas. But yeah, we recently looked at pharmacies opportunities, and so yeah, that's an area where we see as very attractive. We're ourselves investing in our own ability to address the market.
And particular sectors and all?
Dentistry as well, and but pharmacies was an area that we spent a bit of time on the Irish, in the Irish geography.
Yeah, I was travelling between Galway and Cork on the day that the announcements were made around where those taxes, the rebates were going to be spent. It was fascinating to see the list of high-quality projects actually the Irish government's able to invest in. The Irish market's complex, I think. My view on it is, certainly from the sector that we're operating in, I think we would be able to bring something in partnership with Ireland, but I'm be reticent about either a do-to or any entry being led by anyone other than somebody from Ireland. I think that's really important. So are we looking at it? Yes. Dot points on a page for me, it's a fascinating market to get into, particularly given the prevalence of both cancer but also private medical insurance, but I think it has to be locally led and locally wanted. Otherwise you're up against a really difficult set of prevailing factors.
Yeah, I mean, we're very excited about Ireland. We hope that that's our next country. The HSE is not entirely easy to deal with all the time, and nor are the insurance companies that relate to them. So you will know the process of getting codes to be able to operate in Ireland is not easy, but we think it's a really great market, and we're excited about it.
And a different regulatory model because they don't have the Care Quality Commission, so it's more difficult in a way for investors. I think you have to be on the ground to see what's going on.
It's more difficult and easier because you've got less ideology. So yeah.
Kind of last round for any questions before we. I'm going to ask our. I haven't missed anyone. Last round of kind of thoughts as we are kind of moving into this year. What other kind of what have we not discussed that we think that will be the big opportunities, the areas for growth for investors? What if you were to kind of name the sectors and all of the. I mean, obviously, other than social care and education, private oncology and ophthalmology, putting those aside.
I mean, we're a generalist healthcare fund, so we do look at a lot of other subsectors, and there are a lot of excitement. But what I wanted to emphasize, actually, I'm sorry, it's slightly diverted to your question, but having looked over the last few years at the hype sectors like outsourced pharma services, etc., which obviously had a very strong 2021, 22, and then obviously much more difficult 23, 24. The healthcare services and social care are quite steady sectors. I mean, they're really essential services and supported by. So I think it's been a bit kind of less looked at the last
and loved.
And exactly, absolutely, and they're exciting sectors, and they're so I'm more bullish on those than I have been in the last few.
That's interesting because that's absolutely. I mean, that's absolutely fair enough because pharma and pharma services became very hot topics, but ultimately the drivers around healthcare services remain very strong. Seb, I can see you.
Yeah, I think
to say this.
Generally speaking, if we're going to solve this problem in any country, we're going to have to triage more effectively into people doing work which is at the top of their license. And community pharmacy and help in community should be doing much more in the primary care space. GPs should be doing much more in the emergency space and a number of other areas, and so on and so on. Only by doing that are you actually leveraging the resources you've already got. And at the moment, you've got, certainly in the UK, you've got GPs doing things that pharmacists should absolutely be doing, and so on all the way up the chain.
So, I mean, I'm entirely confident about the prospects, given that sort of imbalance, if you like, of supply and demand. I think Anita made a point earlier, which I think is often overlooked because it sits in the too complex category, which is, for me as an observer standing back looking at the reform that needs to take place in order to have a successful outcomes-based healthcare system, we cannot, and unfortunately we're in a situation now where it is the case, we cannot divorce health and social care. And while it sits under one department, it does not sit in any way on a cogent timeline for resolution. And that is a fundamental issue that government has to get to grips with before it starts trying to drive through elective recovery transformation, because otherwise it simply won't happen to the extent that it should.
So are you talking about move to a different funding model? So moving to an insured, co-insured model?
Possibly, but I think an all parliamentary party consensus is what they're going to need to drive that through. Whether or not that requires primary, secondary legislation, TBC. But of course, there have been several successive, under the Conservative Party, several successive and aborted attempts at that reform. We have to go back to the table and try and solve that.
Anita, any final thoughts from you?
See, I operate in a undersupply, high demand environment, and so that for us means that we will continue to help the people that that exist for us, and so less political for us really than the rest of the panelists. But we know a million people have a learner disability in the UK. 400 million have EHCP as children, that stat continues, and we need providers like ourselves that really support young people and adults with complex needs to live a fulfilling life, and that's what I will continue to do.
Excellent. Well, I can't think of a finer way to finish this panel, and I also wanted to ask you all to give them a huge round of applause. Experts playing at the top of their field.